Welcome back, everyone. In this mini lecture, I want to give you some background information on Atul Gawande. He's the second author that we will be discussing this week. Atul Gawande is a currently practicing physician, author, and public critic and intellectual. He practices general and endocrine surgery in Boston at Brigham and Women's Hospital, and he is a professor in two different departments at Harvard. He works as a professor of surgery in the medical school and as a professor of health policy and management. He's also been a staff writer for the New Yorker magazine since 1998. And he's written for many other journals as well. He's also performed at least one TED Talk that I know of, and he has written 4 New York Times bestsellers. The first is a work called Complications, A Surgeon's Notes on an Imperfect Science. The second is Better. The third is The Checklist Manifesto. And the fourth is Being Mortal, Medicine and What Matters in the End. So in a way, he reminds me a bit of William Carlos Williams, as they are both physicians and authors, and they're physicians and authors that view that relationship between medical practice and writing as being seemingly symbiotic. He's also just one of my favorite contemporary authors. His writing is beautiful, and his ideas are really incisive and intelligent. He thinks deeply about medicine from the perspective of a doctor. He's talked about it from the perspective of a parent of a child who needs medical care, and also just from the perspective of someone who understands health policy and population-wide medical concerns. The first of the 2 articles that we're going to be reading is a short article called Naked. In Naked, Gawande discusses the issue of patient exams and disrobing. And he uses that as a jumping off point to think about the best way for doctors to maintain and articulate the maintenance of a sense of professional distance from their patients. And we might consider reading Naked alongside the use of force, because it strikes me that they might both be sort of interested in the same thing. And by this, I mean that Gawande seems to be discussing sort of the way in which doctors can balance out this need for professionalism and the need to be accessible to their patients. And it strikes me that Williams might be doing the same thing in the use of force. He's describing a physician that is also trying to maintain a sense of professional distance, but is letting sort of his emotions get in the way. So he's sort of skating that line between kind of personal thoughts and the necessity of professional distance. The second article that we're going to be reading by Gawande is called Letting Go. It's one of my most favorite articles. In this, he examines end-of-life care for terminal patients and considers the question of how doctors and also how modern American culture does approach dying and really should approach dying. I know that the issue of death and dying has been a topic of interest in this class. Students have expressed interest in the culture surrounding death and dying in modern America, the seeming discomfort that Americans have with dying, and also the kind of bioethical considerations that come up for medical practitioners when it comes to caring for patients who are dying. Now, Gawande argues that modern medical technologies have begun to chip away at a long-standing culture of dying that had historically existed. And he alludes to something that we noticed as early as Boccaccio, which is that there appears historically to have once been a pre-existing set of rituals that society followed for when someone was dying and then when they died. Now, what Gawande argues is that modern medicine can delay death to the point that doctors and even patients may no longer be able to distinguish when someone is dying. And by this, I think he means that it's incredibly tough in general for doctors to advise their patients to stop treatment and just accept the inevitability of their own death, even when the patient has reached the point where there's no cure for their illness, their treatment is not working, it's making them sicker, and their own death is really sort of fast becoming imminent. So what he does in order to explore this topic is he compares patients who are on hospice to one patient, a young woman, who is receiving extensive, aggressive, ongoing chemotherapy for treatment of cancer. And he embarked on this comparison in order to point out a couple of things. One is that sort of aggressive medical treatment for cancer and hospice care both actually end up extending patients' lives and seem to extend them for about the same amount of time. So his point is that if doctors assume that aggressive medical treatment is necessary to prolong a patient's life, they may wish to reconsider this in light of the fact that we know that hospice does this too. And the second thing that he points out is just the difference in approach between hospice versus sort of traditional oncological care. He argues that individuals who are enrolled in hospice focus more on identifying what matters most to them in their lives and then teaming up with their hospice team in order to make those goals achievable. Um, and what he points out is that patients on hospice tend to have many fewer visits to the ER, fewer visits to the ICU, and they seem to be able to, in large part, to get closer towards achieving what he says is a goal that many patients express, which is the desire to die at home in peace, surrounded by family, and even with good pain control and possibly a sense of sort of dignity in the end. So I'm really interested in hearing what you guys think about this article. So at this point, I am going to end this mini lecture and turn over to the discussion board, and I will look forward to meeting you there. Thanks.